Hello and welcome to today's presentation. Today we are going to look at acute coronary syndrome. Once we've seen the clinical presentation, how do we classify this acute coronary syndrome? So you ask the patient, since when did the pain start? The patient tells you, it's been more than 20 minutes since I had the pain. It's about an hour since I've been getting this pain. If the patient tells you it's more than 20 minutes, quickly your attention should be drawn to an acute coronary syndrome. But if the patient says no, it's been less than 20 minutes, about 5 minutes or 10 minutes, then it can even be a stable angina, or sometimes even not a cardiac, origin of pain at all. Now, if you suspect acute coronary syndrome, then as soon as possible we must take the ECG. What do we look for on ECG? On ECG we must check, is there an ST elevation or not? If there is an ST elevation, then our diagnosis of ST elevation myocardial infarction can be put. If there is no ST elevation, then we must do our labs within 3 to 4 hours. And if in our labs, we must look for cardiac markers such as the troponin level. If troponin is elevated, but there is no ST elevation, then our diagnosis of non-ST elevation myocardial infarction can be put. But if there is still no troponin elevation and also there is no ST elevation, then we can confidently say this is an unstable angina. After a day or two, we can repeat the ECG, and if we find pathological Q waves, then it will be Q wave myocardial infarction, and if there is no Q waves, it will be a non-Q wave myocardial infarction. So after this, what do? We need to investigate. With the investigation, I've not written it accordingly, but we need to do all of this. So basically, the common ones which can be done, CBC must be done, in order to assess some disorders that can affect the blood cells, such as anemia and also even infection. We must also order for a comprehensive metabolic panel, and this may include the urea and electrolytes, the glucose levels, the lipid profile, liver function test, as well as the kidney function test. Why do we need all this? We need it to help us evaluate the person's major body organs to see whether there are any excesses, deficiencies, or dysfunctions that may be causing or worsening the person's symptoms. Now, the first instrumental investigation that must be made is the ECG, and it is a key investigation. Now, what do we look for on an ECG? As we've seen earlier on, we are going to look for either there is an ST elevation or ST depression, or there is no changes at all. I have a separate video on ECG signs of acute coronary syndrome, and so we can watch it later on. So I wouldn't explain or go into details of the ECG signs in this tutorial. However, the next laboratory investigation that we need to undertake is the cardiac markers. So we need to do what we call the cardiac troponin test. Why do we do the cardiac troponin test? Because we do it because it is sensitive and specific for acute myocardial infarction, and it is recommended to be in the diagnosis because it is going to help us, one, to detect if there's going to be reinfarction, and also to help us to evaluate our prognosis in all patients who are having acute coronary syndrome. Now, this cardiac troponin may be elevated as early as 2 hours of the onset of an ischemic attack, and it may peak at around 12 to 18 hours, and it may remain elevated for approximately 14 days. And so it should be requested when the patient presents, and also after 12 hours of the onset of symptoms. Now, the higher the troponin level, the greater the 30-day and 6-month mortality. This may indicate, an extensive damage. We also need to do chest radiography. We need to do chest X-ray in order to exclude other causes of chest pain and dyspnea, such as aortic dissection. Now, the gold standard for assessing coronary artery is the coronary angiograph, and so this is the gold standard. In an exam, if you are asked the gold standard, it is acute, it is coronary angiography. If you are asked for the first investigation to be done, it is electrocardiography or an ECG. Now, why must we do coronary angiography, or why is it the gold standard? It is because it helps us to assess the exact location of the coronary vessel, which is stenosed, even before we go in for a PCI. PCI meaning percutaneous coronary intervention or stenting, or even if you want to do surgery for this patient. And so coronary angiography must be undertaken or performed to patients who are medium to high risk, of acute coronary syndrome, patients who are having STEMI, and patients who are having unstable angina. We need to do this in order to see whether they may be progressing to developing STEMI or not. Now, we also need to do echocardiography. Why must we do echocardiography? It will help us to assess the presence of original wall motion, the function, the pumping function of the heart. We can see it when we take an echocardiography. So if there is or if there are any regional wall motion abnormalities, and also if there are valve disturbances and even complications of myocardial infarction, we may find all of them when we do echocardiography. We used to do creatinine kinase because it was, this isoenzyme was exclusively found in cardiac tissue, and so its presence was pointing to a myocardial infarction. But with the presence of troponin, this test has been suspended, and we don't usually undertake it. Now, quickly, let's see one or two things about STEMI, STEMI, and unstable angina, then we manage. Now, when we say STEMI, what we mean is there is a complete occlusion of the coronary vessel by the resultant thrombus, which was formed when the thin fibrous plaque was disrupted, and so infarction may ensue and necrosis may develop rapidly. How is it characterized? It is characterized on the ECG by an ST segment elevation. And so in this diagram in the middle over here, you see that there was a thin fibrous cap over here which got ruptured, and so clot began forming, and it formed the thrombus, and it blocked the entire lumen of the coronary artery, and so blood supply to that part of the heart was cut off. And so this is what we call a classic heart attack, and it causes an extensive damage to the heart. So on an ECG, this is what we see. The first one here on the right shows the normal ECG, and as you can see, this is the isoelectric line. And as you can see, the J point is also on the isoelectric line, and this is the T wave. And so in this ECG, there is no abnormality. This is normal. But if you look at the second one, look at the isoelectric line over here, and look at where the J point is over here. So there's an isoelectric line, and as the arrow is depicting, there is an elevation of the ST segment. So our S segment, our S wave will be here, and this will be the T wave. The T wave will also be here. So this is an ST segment elevation in STEMI. Now, when we say STEMI, what do we mean? In STEMI, the thrombus is formed within a thick fibrous cap, and so it does not completely occlude the whole vessel. What do we see? ST changes may occur. There may be ST depression and or T wave inversion, and there is always also increase in troponin. And so as you can see over here, there is reduction in the lumen of the vessel, and and so blood still goes to that part of the heart, but it may not be sufficient enough, and so it may cause an intermediate form of acute coronary syndrome, causing a less extensive damage to the heart as compared to the STEMI. And so on an ECG, this is what we see. This is our isoelectric line, as you can see over here, and as the arrow is pointing, the ST segment is depressed, and the T wave is also inverted. Normally, the T wave must be like this. Okay, so this is what we see on an ECG in STEMI. Also, in unstable angina, there may be no myocardial necrosis. There will be no troponin, level elevated, and ST depression may be depressed, or we may have a T wave inversion. Yeah. So, how do we manage this patient? Quickly, we need to continue with our cardiac monitoring in order to rule out any possibility of ventricular tachycardia or ventricular fibrillation. And so our aim of management is to initiate an antiplatelet therapy as soon as possible to reperfuse the myocardium in STEMI, and also to prevent the progression of unstable angina and end STEMI to a STEMI. So what do we do? Quickly, we can give oxygen, or we have to give oxygen to this patient. 1 to 8 liters per minute per nasal oxygen tube can be infused. Now, some studies say that oxygen therapy is indicated if SpO2, or the saturation of oxygen, is less than 94. Because they suggest that oxygen has a potential vasoconstriction effect on the coronary arteries, and so should be avoided. But you are, managing the patient. If the patient is hypoxic, you will see. If the patient is not hypoxic, you will see. But go in for oxygen therapy and administer it. We can give glycerol trinitrate sublingually to reduce the pulmonary congestion and also provide a symptomatic relief of the chest pains. Why must we give triglycerides? Because it is important. And another important thing is we have to avoid the usage of triglyceride nitrate if the systolic blood pressure is below 90 millimeters per mercury. Then we must give aspirin. 300 milligram is the most important intervention in acute coronary syndrome. Why is aspirin the most important intervention? Because it lowers mortality. We also have to give our antiplatelet agents such as the clopidogrel, also prasugrel. We can give any of these. I will go for clopidogrel 300 milligram before or whilst we transport the patient to a PCI center, in addition to the aspirin, because it also lowers mortality. Then we can give morphine to reduce the pain and anxiety, as well as pulmonary edema. And this morphine should be given alongside with metoclopramide in order to reduce, the nausea and vomiting associated with morphine. Then we must control the blood glucose level. Then we must do an early risk stratification to determine if this patient is a STEMI patient, NSTEMI, or unstable angina. If the patient is STEMI, if there is ST elevation myocardial infarction, patient must be transported immediately to a percutaneous coronary intervention center where stenting can be done for this patient. And so a short mnemonic for the management of this patient, we have the MONA, signifying the morphine administration, oxygen administration, nitrate, as well as oxygen. Now, what are the complications that we may find in acute coronary syndrome? Basically, we have the early complications and also the late complications. Early complications, there may be sudden cardiac death, which is obvious based on all that we've talked about. There may be sudden cardiac death. Then also, there may be AV block, ventricular tachyarrhythmias, which could be very, very fatal. Then we may also have acute left heart failure. The acute left heart failure may be evident in pulmonary edema and may result from acute pump failure of the heart and acute mitral valve insufficiency, which is usually secondary to papillary muscle dysfunction. There may also be cardiogenic shock, and this is the most serious complication because it carries a 50%, more than 50% mortality rate. With the unstable angina, with the late complications, we are going to have pericarditis, and this pericarditis may be divided into two. We can have the early infarction associated pericarditis, which may occur within the first week of myocardial infarction. Then we may also have what we call the Dressler syndrome, which is the pericarditis which occurs between 2 and 20 weeks after myocardial infarction without any infective cause of the pericarditis. And this is usually secondary to circulating antibodies against the cardiac muscle cells. There may also be reinfarction due to unstable plaques, which may be still present. Then lastly, we are going to have atrial and ventricular aneurysm. And this atrial and ventricular aneurysm may precipitate the formation of thrombus and also increase the risk of embolism. It may also precipitate cardiac arrhythmias and can also even rupture. The aneurysm can even rupture, leading to pericardial effusion and also cardiac tamponade. So, how do you summarize everything that we've learned so far? With unstable angina, the clinical features is chest pain that may occur at rest or with previously tolerated levels of exertion. ECG findings, usually there may be none, but there may be ST segment depression. There are no laboratory findings that may point to unstable angina. If it is STEMI, there is also chest pain in any setting of STEMI. ECG findings, there may be ST segment depression, and laboratory findings may pinpoint to elevated troponin levels. And if it is STEMI, there is also going to be ischemic chest pain in any setting. There is also going to be ST segment elevation on the ECG, as well as elevated troponin levels in laboratory findings. So this is what I have for you. It's a bit long, but this was how I was able to manage to do this. Thank you very much for your time. Bye-bye.